Hello, my name is Dr. Dave Webster, and this is part of my ongoing video blog series about the travesty of lack of access to PET-CT in Ontario. This one, surprisingly for some, maybe, is entitled, Will Cancer Care Ontario Force Me to Assault My Own Patient? Now, to use the word assault, I assure you, is not an exaggeration. Ontario physicians are forced to investigate their patients as if we were living in the 1990s, and I will show you numerous case examples of where this can lead to severe physical and emotional trauma unnecessarily to these patients, and not infrequently results in premature death from cancer and other illnesses. But the Ontario government and Cancer Care Ontario have done such a great job at misinformation that most Ontario physicians are not even aware that they're doing this to their patients. However, dare challenge Cancer Care Ontario with this position, and they will threaten to take away your hospital privileges. So this video will be hopefully a brief and account of using something called positron emission tomography or PET scanning to demonstrate as the best example of how critical decisions, healthcare policy decisions, are made in Ontario. Now, it turns out that PET scanning has been the accepted world standard of imaging management of cancer, dementia, and other patients for over 20 years, and that today, unless you live in a poor third world country, or as it turns out, Ontario, Canada, you would typically have access to this in any jurisdiction, medical jurisdiction, calling it an advanced medical jurisdiction. In the 1990s, PET came on the scene, and it was the most advanced imaging device we had to directly image cells metabolizing things, making DNA, cell walls, and so on, and it rapidly became the accepted world standard of imaging management, as I said, of cancer, brain, things like dementia, head injuries, and cardiac, and so on. Now, it turns out that glucose is the basic fuel for all cells, and so in PET-CT, we mostly just inject less than a billionth of a gram of radioactive glucose. Now, fortunately for patients who do not live in Ontario, cancer cells can only use glucose, and they do it so very inefficiently, so they tend to stand out against the background. And what I'll show you here is a three-dimensional rotating image of a PET scan, of a sugar scan effectively, or what we call fluorodeoxyglucose, or FDG, and quite literally this is an image of the cells directly imaging or eating up sugar, as it were, the heart, and so on and so forth in this case. Now, here is an example of a patient with lymphoma, very clearly showing that cancer cells do so inefficiently, and you might imagine how this could be extremely useful for a patient. Now, again, here is a picture of a PET scan. This is the heart here, and liver, spleen, and cancer here, but it's typically is performed with a low-dose non-contrast CT. They are fused to produce what we call a fused PET-CT image, which has great advantage to us. But of course, you're most familiar with the CT portion of the study. So what I'm going to use as an example is this 80-year-old female with lung cancer, and this is the right lung and the left lung, the back of the patient in the front, and I'm sure you've all recognized that this probably shouldn't be here, and this CT reported appropriately that this is most likely a lung cancer. But as you will see with this example, it demonstrates the severe and critical limitations of CT, using CT to manage cancer patients. However, this was the standard of care in the 90s before PET came along. Now, a summary of the key issues is that in the 1990s, an Ontario team of experts in imaging and cancer looked at the world literature and said 40,000 patients would benefit for 5 indications immediately. The government read that report, and they decided they weren't going to pay for it. So what they did is the government gathered together the senior executives from Cancer Care Ontario. I'm not sure that Michael Scherer was head at that time, but he is now. And they were told, you are going to do whatever is required to discredit this accepted world standard, because we simply are not going to pay for it. They would partner with McMaster Health Sciences, who would then, in the faculties of McMaster, develop the necessary evidence-based medicine tools, as they will call them, to carry out this investigation or this mandate to discredit PET. Now, they will claim, as they do to this day, publicly at least, that they're using rigorous science. However, in a conversation with Dr. Julian Dobranowski from Cancer Care Ontario, he admitted that there is absolutely no evidence or scientific basis to use their evidence-based medicine tools to evaluate any imaging device, whether it's PET, CT, or MR, but he was very clear they're going to continue to evaluate PET by this technique. Now, the first report from Cancer Care Ontario was in 2001, headed by this man, Dr. Andreas Lopalkas, and believe it or not, he reduced that recommendation of 40,000 patients from those independent, non-government-based experts to 0. And he would do so, of course, using what is now fully understood to be a political agenda and not science. But now what is Dr. Lopalkas doing to this day, and I hope you're sitting, he is now head of something called Health Quality Ontario. Now, what is the recipe for making critical healthcare decisions in Ontario? Quite literally, it's as simple as this. The government decides what they're going to pay for under OHIP, and then the medical experts from Cancer Care Ontario and McMaster set about creating, as it were, the so-called evidence that is required to justify the position of the policy the government has already taken. Now, in fact, how successful has this been? In 2017, the Ontario Auditor General reported that Ontario patients have the least number of scans per thousand population in the entire world where PET is offered for the benefit of patients. However, it turns out this is not the bad news. Up to 90% of the OHIP-funded indications physicians are allowed to use are the exact opposite of the entire world expert body of opinion. The use of these indications by physicians in Quebec, or for that matter Paraguay, would result in charges of incompetence. Why? Because it is well acknowledged that this can lead and does lead to forcing an assault on our patients. However, by sharing this information with physicians and patients and all the documents backing my statements, I have been threatened by Cancer Care Ontario and the College of Physicians and Surgeons with loss of my medical privileges. Now, in 2005, the Canadian Association of Nuclear Medicine was so horrified they passed motions declaring the trials unethical, but most importantly demanded an independent review by Canadian experts in ethics and health policy to independently determine how this possibly could have happened in Ontario. The government to this day, along with Cancer Care Ontario, McMaster University physicians, pretend this report doesn't exist, and they've refused to act on it. In 2009, in fact, the most senior member of the government PET steering committee resigned, saying what the experts were doing to patients bordered on immoral. Now, this is Professor Rodney Hicks from Australia, an acknowledged world PET expert. And what he said to me in 2016 was that, and I quote, Ontario has the most egregious and politically motivated agenda against PET, and of course, read our patients in the world, end quotes. Another accomplishment of Professor Hicks was that his investigation and exposure of what the Australian government was doing to patients to block PET led to criminal charges against government senior bureaucrats and experts. Now let's go back to that image I showed you about the 80-year-old woman to help you understand why PET became the world standard. So this is an image of this patient, and because she has the misfortune of living in Ontario, before we can order the PET scan, we have to do a lung biopsy. So we have to insert, this is an image representation of a 15-centimeter needle that we inject, push through the patient's back and into the mass itself to get some cells to see if they could determine what the cause of this mass and confirm that it was cancer. However, what happened to this patient during the biopsy? Well, something that happens quite commonly, as a matter of fact, and that is the poking the needle through the lung caused it to collapse or leak lots of air, and the lung collapses. And as you can see, a representation of the collapsed lung. As you might imagine, this not only is a threat to the patient's survival, but is extremely uncomfortable. What is the treatment? That patient then underwent what is insertion of a chest tube in this fashion through the chest wall. She spent several days in hospitals and weeks recovering from that compulsory procedure in Ontario. However, the bad news for this poor woman, after going through all of that, the CT-guided biopsy comes back not showing any cancer. But how could this be? Well, here's a fused PET CT image. You can see the CT and the colors represent the active. This is a sugar scan, and this is where the active cancer cells happen to be. But because we live in Ontario, we had to stick the needle, and as you can see, it's actually in scar tissue. This is dead cells. This is not. By using PET CT, as you can see, we should have put the needle here, and that's why we use PET before we biopsy, so we can find the best place to get the most likely result, and also, as you will see with this case, the safest and most easily accessed and least stressful and uncomfortable to the patient to do that. But the patient lived in Ontario and had to have this biopsy and went through all of this. But in addition, it was even worse. To add further insult to her already being assaulted by her physicians was that the PET scan also showed that she had a spread of cancer to something called a Virchow's node. This is a little lymph node sitting right above the clavicle here. This isn't the patient herself, of course, but the point is I think you can readily see that this would be incredibly easy to biopsy with insignificant risk to the patient, minimal discomfort and anxiety, the quickest possible way of getting the answers this patient needed. So I ask you to consider, did Cancer Care Ontario force this patient's physicians to assault her, or did they not? So I'm now presenting another patient to Pet Access who's rejected my previous applications, and this is the Pet Access site, and I want you to concentrate on the statement. PET Scans Ontario uses an evidence-based medicine approach to ensure proper access to PET scans in the province of Ontario. But you know, and of course they know, that this is based on a political agenda and not based on any method that relates to science. So therefore I say to you, Dr. Michael Scherer, who's current President and CEO of Cancer Care Ontario, and Dr. Joe Bernowski, provincial head of the Cancer Imaging Program for Cancer Care Ontario, go ahead. I challenge you to publicly try and take away my hospital privileges. I am honored and proud to stand up in front of for this patient and try and protect her from all things Cancer Care Ontario. I will not break my Hippocratic oath to this patient, which says I must first do no harm to my patient. I will not abandon my primary role as an advocate for my patient, and I will do so publicly. The question is, are you prepared to defend your actions publicly? Now, if ever something on the internet needed to go viral, I would suggest that it is this. We need to get this information out to the public, and why that we have to use the internet is because, as you would have guessed, our so-called quotes professional journalists and news anchors, end of quotes, have been protecting the Ontario physicians from this for all this time. We also must insist that those motions from 2005 get carried out, in particular the review by the ethics experts, to ensure as much as possible this never happens in Ontario, for that matter Canada, again. So I would ask you to visit my website and my social media sites, where I'm rapidly uploading all of these 15 years of documents for the public to view. And my next video blog will be entitled, Does McMaster University Have No Shame? Thanks for your attention, and do what you can. Appreciate it.